The boldest changes I was part of didn't come from a consultant's report. They didn't come from a board retreat or a leader's strategic planning day off-site, though Lord knows I've sat through plenty of those. They came from the moment when someone, usually someone with very little institutional power, said, "This doesn't work. It's hurting us." Welcome to Health Hats, the podcast. I'm Danny Van Leeuwen. Healthcare is an awesome circus. Let's wear some hats and see if we can find our way to best health. I spent most of my career in institutions, hospitals, managed care companies, and disability services agencies. These are large, slow-moving systems with their own inertia, logic, and knack for designing processes that work best for billing and not so well for those receiving or providing services. I should know, because I've been inside these systems as a clinician, a boss, a consultant, caregiver, and patient. The boldest changes I was part of didn't come from a consultant's report. They didn't come from a board retreat or a leader's strategic planning day off-site, though Lord knows I've sat through plenty of those. They came from the moment when someone, usually someone with very little institutional power, said, "This doesn't work. It's hurting us." My secret as a consultant was embarrassingly simple. The people who hired me already had the answers they needed. The nurse who'd been there for 15 years knew. The member who couldn't get her calls returned knew. I sought them out, listened, and translated their words into a PowerPoint that the boardroom could hear. I want to tell you about 3 times I got it right. 3 moments when the change that mattered was a no. No to visiting hours that kept families from the people they loved. No to a prior authorization process that treated patients and clinicians like suspects and required an army to administer that suspicion. No to a system that let care aides disappear from people's lives without warning a goodbye, as if the people whose lives they were in didn't deserve a heads up. None of these no's were mine originally. I heard them from a family pacing a waiting room, from a member who couldn't get the help she needed, and from a man with a disability who sat in on our board and told us plainly what it felt like to wake up one day to find that someone essential to his life was simply gone. Seven visits, no questions asked. My title was Director of Quality at a behavioral health managed care company. So prior authorization was the centerpiece. A member needs therapy. Their provider submits a request. Someone on our end reviews it, approves or denies it, requests more information, waits, and follows up. My boss and I set up an advisory group with members on one side and providers on the other. We asked about their experiences with our company. They were not settled. Members said the pre-auth process made them feel they had to prove they deserved care. Providers said the company's default assumption was that they were lying. Neither response was a ringing endorsement. So we experimented. 7 visits upon request. No pre-authorization required. If a member or their provider asks, they get them. No forms, no review, no waiting. The result? The outcomes held. Members received care faster. Providers stopped spending half their administrative time on the phone with us. And our call center, the engine room of the prior auth machine, grew quieter. Then quieter still. A substantial portion of our staff spent all day managing a process that in large part was designed to manage itself. Strip it out, and you didn't need nearly as many people to run it. The bureaucracy wasn't protecting anyone. It was the cost. We had real data. Member satisfaction trended up. Providers, for the first time in recent memory, said something positive about the company. The advisory group had surfaced a truth that no quality metric had found, because no quality metric had asked the right people the right question. The right to say goodbye. There's a particular kind of organizational meeting where everyone knows something is wrong. The data is right there on the slides, and somehow the conversation goes nowhere. Lots of nodding, lots of concern, lots of commitment to further analysis. I worked as the VP of Quality at an organization supporting about 40,000 people with disabilities, many of them living in group homes, relying on personal aids for the most intimate parts of daily life, getting dressed, eating, toileting, moving through the world. At my first board meeting, we reviewed satisfaction results, which were poor. They were not nuanced, requiring careful interpretation. They told us something was bad, and we were doing what organizations do, analyzing, discussing, and scheduling follow-up meetings to review the analysis. We were not asking the people who lived there. The agency was committed to patient-resident participation in governance committees, including the board. In this case, the resident of one of our group homes served on the board, not as a symbol, as a board member. At one of these meetings, in the middle of what was shaping up to be another productive session of collective concern, he said something that stopped the room. He said, people leave without warning. A personal care aide, someone who helps you start each day, who knows how you take your coffee, which jokes make you laugh, and how you like your blanket folded, is just gone one morning. No notice, no goodbye. Someone new shows up and you're expected to adjust. He said it plainly, not as an accusation, but as a fact. He apparently assumed incorrectly that we already knew, but we didn't. Or rather, someone knew. The people living in the homes knew. The aides probably knew. It just hadn't made it into the meeting until he put it there. The fix was insultingly simple. When an aide left for any reason, residents would be told in advance, a chance to say goodbye, a proper introduction to whoever came next, rather than a key, an address, and a good luck. That was the intervention. Advance notice, a goodbye, a hello, the basic courtesies we extend to anyone, anywhere, in any context. Survey results improved dramatically in the next cycle, not in one or two categories, across the board. Because what was wrong wasn't a program or resource allocation, it was that the people living inside the system had been treated as though their experience of it didn't count as information. The lesson I carried from that room is the simplest I know. The person living inside the system always knows. They know what's breaking, what would fix it, and they've usually been waiting, sometimes for years, for someone to ask. I got lucky 3 times. I was in the right seat and the right person was willing to tell me what I needed to hear. Not every leader gets that, and not every leader goes looking for it. The question I leave you with, the one I still ask whenever I walk into a new system, a new organization, or any room where decisions are being made about people who aren't present, who already knows the answer, and what would it take to let them say it out loud? If you've been in that room where someone finally said the quiet part and the right no was finally spoken, I want to hear about it. Find me at Danny Health Hat's one word, at Gmail. Tell me your version. I promise you it's better than you think, and someone out there needs to hear it. Thank you. Health Hats is produced by me with Kayla Nelson and Team Van Leeuwen, Leon, Oscar, and Joey. Joey arranged and recorded the intro and outro music. AI tools assist production. I make all creative decisions. If you like it, share it. Subscribe at linktree/healthhats. That's linktr.ee/healthhats, one word. See you around the block.